Well, hello, everyone. We are very glad that you've joined us today for our webinar presentation, Understanding the Opioid Crisis, What's at the Heart of the Matter, with our co-host today from the Centers for Disease Control and Prevention and the Substance Abuse and Mental Health Services Administration. My name is Heidi Christensen, and I am with the Center for Faith-Based and Neighborhood Partnerships here at the U.S. Department of Health and Human Services. The Partnership Center, as we're known, works to support faith and community health leaders with timely information, best practice sharing, and resources that we hope will help strengthen our community partners' capacity to address public health initiatives and public health crises, such as the opioid addiction epidemic that so many communities are struggling to respond to, and is one of the top 4 clinical priorities of our HHS Secretary, Tom Price. We hope this next hour, exploring the evidence and science about opioid addiction and dispelling some common misconceptions about treatment and recovery, will be helpful to you and your community as you seek to understand the issue and support those suffering with addiction. A few housekeeping notes before we begin. First, this call is for educational purposes, so it is off the record and not for press purposes. If you are a member of the press, if you could disconnect and contact us after the broadcast, we will be happy to connect you to the press office here at HHS. So folks, we welcome your questions and comments throughout today's webinar. You should see a control panel on your screen with a text box in the lower right-hand corner. Please use that box to type in your questions or comments throughout the webinar and at the Q&A breaks. So we'd like to do a test run and at the same time let our presenters know where people are participating from. So please now type in that box what city and town and state you are listening in from. Well, we have Oklahoma and Chicago, Atlanta, San Francisco, Honolulu, New York, Edison, New Jersey, Canton, Connecticut. Great, thanks folks, wonderful. Thank you so much, terrific. Please use that box for questions and comments throughout the hour. We will refer to your questions for the Q&A, and then we'll also share all comments that come in today with our presenters after the broadcast. So we look forward to hearing from you. And as a final note, we will be emailing a link to the slide presentation to all those who registered for this webinar. And we will also be sending, and here's a little bit of a drum roll, a copy of the Partnership Center's newly released Practical Toolkit for Faith and Community Leaders in the Face of the Opioid Crisis. It is our greatest hope that this toolkit will support your efforts in practical ways to usher in a culture of compassion toward those struggling with addiction and its often severe consequences. And I'll say more about that toolkit later on, but it's time now to turn to today's presentation and to our presenters. Our subject matter experts from the Centers for Disease Control and Prevention, the CDC, and the Substance Abuse and Mental Health Services Administration, SAMHSA, are here with us today and next week. During this first of our 2-part series, our presenters will unpack the complex factors that have contributed to the current opioid crisis and offer an evidence-based perspective on treatment and recovery. They will also address the very nature of addiction as a disease and chronic condition and explain how people develop substance use disorders to begin with. We will break for a Q&A between speakers and again at the end of the presentations. First, we'll hear from Sarah Patterson, the Associate Director for Policy at the National Center for Injury and Prevention and Control at the CDC. Sarah oversees health policy, partnerships, and has a background working on the Kids Public Education and Policy Project for the Ounce of Prevention Fund in Chicago. She will be followed by Dr. Melinda Campopiano, who is a medical officer for the Center for Substance Abuse Treatment at SAMHSA. She is a physician in family medicine and has worked in both primary care and addiction medicine, including managing programs and patients using medication-assisted treatment, and so has a frontline experience with those seeking and sustaining recovery. Sarah and Melinda, we are so very grateful for your participation today and eager to hear from you. Sarah, are you ready to start us off?
I'm ready. Thanks so much for that introduction, Heidi. Can everybody hear me okay? Heidi, can you hear me okay?
I can hear you very clearly, and hopefully our community can as well.
Great. Well, we're just so thrilled that the HHS Partnership Center invited us to present to you all today, and I'm honored to present alongside Dr. Campopiano from SAMHSA. As many of you know, the United States is in the midst of an opioid overdose epidemic, and today I'll share an overview of where we are with the epidemic, how we got here, how the epidemic's changing, and who's at greatest risk. Our hope is that by better understanding the data, community leaders like you will be empowered to drive action and get help to those who need it most. This is a really exciting opportunity for us to speak to this broad of an audience, and we're really looking forward to your questions and to an ongoing dialogue. Next slide, please. So I just want to run through sort of a history of this epidemic. We always say a picture is worth 1,000 words, and this really holds true for this epidemic in particular. These time series maps that I'm about to show you represent county-level drug overdose death rates shifting between 2000 and 2015. So you'll see here, this is 2015, and the next slide will move us to 2005. And then this following slide will go to 2010, and you start seeing more red. And then in 2015, you see there's quite a bit of red on the slide. So as you've seen here, every state has really seen a dramatic increase in drug overdose deaths, with some states in Appalachia and the Northeast and Southwest being among the hardest hit. And I'll talk a little bit more in a minute about what some of that information is behind that, some of these specific increases. Overall, next slide, please. Overall, drug overdose death rates have never been higher, and over 6 out of 10 of these deaths involve opioids. Almost 310,000 people have died from overdoses involving opioids, prescription or illicit, meaning illegal, in the United States in the last 15 years. This is one epidemic. However, there are really 3 waves. The first wave of the epidemic was prescription opioids. Next slide, please. And its toll is still high. Over 183,000 people died from overdoses involving prescription opioids in the United States in the last 15 years. In 2015, we were losing over 40 of our fellow Americans a day to prescription opioids. The purple line on this chart represents deaths related to natural and semi-synthetic opioids, which include the most commonly prescribed opioids, oxycodone and hydrocodone. These increased 4-fold between 1999 and 2011. The methadone death rate increased 6-fold in just 8 years between 1999 and 2007. While it has decreased substantially since then, methadone is still involved in a lot of deaths relative to the volume of methadone prescribed for chronic pain. And I'm not talking about methadone for treatment of addiction. This is specifically for methadone prescribed for chronic pain. The leveling off of the natural and semi-synthetic death rate and the decrease in methadone death rate are positive signs that our prevention efforts to decrease inappropriate prescribing behaviors are beginning to work. I'm going to talk a little bit more about that later. Next slide, please. Let's talk a little bit more about how we got here. CDC was at the forefront of raising awareness of the growing problem more than a decade ago when our scientists, after hearing alarming news from medical examiners in Maine and North Carolina about increases in overdoses connected to prescription narcotic pain medications. Looking nationally at the data, CDC scientists analyzed vital statistics data on overdose deaths and data on drug sales from DEA, or the Drug Enforcement Administration, and found out that overdose deaths were increasing in lockstep with prescription opioid sales. Even though prescription opioid sales were increasing, the amount of pain that Americans reported remained unchanged. What we found was that beginning in the late 1990s, opioids started to be prescribed to treat chronic pain not related to cancer, such as arthritis and back pain. As that continued, more opioid prescriptions were written for more days per prescription and in higher doses. And we've since learned that taking opioids for longer periods of time or in higher doses increases the risk of addiction, overdose, and death. Next slide, please. There's some good news. A recent CDC study found that half of all counties in the United States had a decrease in the amount of opioids prescribed per person from 2010 to 2015. However, the amount of opioids prescribed per person still remains high. In fact, the amount of opioids prescribed in 2015 was 3 times higher than in 1999. So there's still a lot of work to be done in this area. Next slide, please. Opioid prescribing varies widely across the country. The highest prescribing counties depicted on this map in the darkest color prescribe 6 times the amount of opioids per person compared to the lowest prescribing counties, which are depicted in the lighter blue color. Higher prescribing counties are more likely to be rural and are more likely to have a higher percentage of white residents, more dentists and primary care physicians, more people who are uninsured or unemployed, and more people with diabetes, arthritis, or disability. Next slide, please. Our deputy director at CDC, Dr. Schuchat, best summed it up when she said, the amount of opioids prescribed in the U.S. is still too high, with too many opioid prescriptions for too many days at too high of a dosage. And that's one of the things that we're working to address here at CDC, along with many of our federal partners. Next slide, please. Decades of prescribing too many opioids primed the pump for our more recent increase in heroin overdose deaths. We found that misuse of prescription opioids is a major factor in heroin use. 3 out of 4 people who report using heroin in the past year say they misused prescription opioids first. And 7 out of 10 who report using heroin in the past year also misused prescription opioids in the past year too. Next slide, please. So now we'll talk about the second wave of this epidemic. The heroin death rate, the orange line, has increased over 4-fold since 2010, and nearly 13,000 Americans died from heroin in 2015. It's now lagging just behind prescription opioids as a leading cause of opioid-related death. Heroin is most available in the Northeast and areas of the Midwest. According to the DEA, heroin seizures in the United States are 2.5 times higher in 2015 than they were in 2010. Beyond greater availability, increased purity and lower costs have also played a role in the growth of heroin use. Per milligram, heroin is 1/10 the cost of prescription opioids. Heroin use is also growing at a faster rate than any other drug of abuse, increasing 5-fold from 2007 to 2015. Next slide, please. And now we'll move to the third wave of the opioid epidemic, which is fentanyl and other synthetically produced illegal opioids. Fentanyl is a synthetic short-acting opioid and is 50 to 100 times more potent than morphine. It's a drug that's approved for management of acute or chronic pain associated with advanced cancer. Most fentanyl-related overdoses and deaths are linked to illicitly manufactured fentanyl that is laced with heroin. The death rate for synthetic opioids, excluding methadone, has tripled in the last 2 years, and over 9,500 Americans died from synthetic opioids in 2015. Beyond its potency that makes the drug attractive to some users, the low production costs make fentanyl a very attractive option for drug traffickers as well. Next slide, please. So who is at greatest risk of an overdose? Rates of opioid use and overdose deaths.
Melinda, this is Ben. Real quick, let me just, hello, this is Ben. Can you hear me? This is Ben
Yes.
Odell. I'm running technical. I'm just trying to make sure we have your audio correct. 1 second.
Okay.
Thanks, everybody, for joining us. Thanks for letting me know you can hear as well. We're having some people who are saying they're having a hard time hearing. So again, let me repeat something that I just shared. Make sure that your audio is up. Thanks, everybody. Appreciate it. So for those of you who are having audio challenges, again, let me let you know that there is a option to hopefully switch over to a phone call or increase the audio on your computer. And if neither of those are working for you today, again, we apologize, and it should be coming through on the recording, so you should be able to catch it there as well. So thanks so much, everybody, and thanks, Melinda. Sorry for the interruption. Just want to make sure we have everybody being able to hear this great information as much as possible. Go ahead, let's continue.
Okay, thanks. So as I was saying, we want to talk a little bit about who is at greatest risk of an overdose. Rates of opioid use and overdose death are highest among men, people in the working years of life, and non-Hispanic whites and American Indian and Alaska Natives. Poor and rural populations are in general more likely to experience prescription overdoses. People who have mental illness or co-occurring non-opioid substance use issues are overrepresented among those both in non-medically using opioids and those overdosing on them. So some of the map that I showed toward the beginning of the presentation sort of maps onto what we're seeing, which is that poor and rural areas tend to have the greatest risk of overdose. Next slide, please. In 2015, opioid overdoses accounted for more than 33,000 deaths, and an additional 2 million people in the United States were living with opioid use disorder. However, it's important to remember that this epidemic's impact stretches far beyond the lives lost and the individuals living with addiction. We're seeing an increase in the number of babies being born with neonatal abstinence syndrome, a 30% increase alone between 1999 and 2013. Because of opioid exposure during pregnancy, these babies experience drug withdrawals after birth, including symptoms like tremors, seizures, and difficulty feeding. In addition, though this issue has not been studied in depth by CDC, anecdotal data show that the epidemic is driving an increase in the number of children entering foster care as parents and caregivers experience overdose or lose custody. The increase in the use of illicit opioids is also sparking dangerous outbreaks of hepatitis C and HIV infections among people who inject opioids. Sharing needles, syringes, and other injection equipment puts people who inject drugs at higher risk for acquiring hepatitis, HIV, and other infectious diseases. Next slide, please. This epidemic is also taking a toll on our economy. In 2013, prescription opioid dependence, abuse, and overdose cost the United States $78.5 billion. More than one-third of this amount, $29 billion, is due to increased healthcare and substance abuse treatment costs. In 2011, approximately 25% of workers' compensation prescription drug claim costs were for opioids. It's a very costly epidemic in many, many ways. Next slide, please. So as I mentioned earlier, I hope you don't come away from this presentation disheartened. I know this is a lot of sort of doom and gloom data, but we really hope that this will inspire all of us to take action. We have several ways that you can get your hands on the data I've shared today. You can visit cdc.gov/vital signs to read more about the latest data on opioid prescribing and why where you live matters for prescribing behaviors. I hope you'll also share this information with your membership by embedding our microsite into your website, and the information on how to do that is right here on the slide. And lastly, I encourage you to visit our website and explore our state and county level data so you can see the impact this epidemic is having in your state and community. Next slide, please. For example, we have maps that drill down to the county level and tell you more about prescribing rates in the community you live in. Next slide, please. I hope you'll join us next week. I'm excited to share with you some of the early successes we've had in preventing opioid overdoses across the country, and I look forward to sharing and discussing different ways that your organizations can plug into all of the great work going on across the nation. In the meantime, feel free to reach out and email us at the email listed on this slide if you have additional questions that don't get answered on the webinar today, or if you would like to talk in more detail. And next slide, please. I think we now have time for some questions, so I'll pass it back over to Heidi to help facilitate that. Thank you.
Sarah, thank you. That was really, there was a lot of material there, and I know folks were saying there's just so much. It's a lot to take in, and there's a tremendous amount of information there. Folks, please know that we are recording this webinar and that you can see it afterwards and go through at your pace to take in the slides and really the wealth of information. And also, we have so many comments. It's a little hard to see the questions right now, but what we are seeing a lot of questions about the specificity of where, you know, this kind of idea of hotspotting, or where the particular problems are and what kind of demographics and and I'm wondering if you could refer back to, I know you just released your new vital signs for the CDC, and you could talk a little bit about this prescriber mapping and how many people may be able to think about areas of particular need from the data that you've collected, and just talk a little bit more about how that tool might be used.
Sure. So you're saying talk a little bit about the vital, like how the information in the vital signs might be used to just understand who is most at risk?
That's right.
Okay. Sure. Yeah, the vital signs, I think the nice thing about that, a lot of our data often tends to be at a national level or at a state level, but what I like about the vital signs is it really gets down to a local level, looking at prescribing, and helps states understand where prescribing might be happening. It could be happening for a variety of reasons. It's not always easy to tell why prescribing behaviors vary from place to place, but some of it could have to do with the risk factors that I put on the slide about demographics. So there might be places where there are higher levels of jobs that cause things like back pain, or people that are living with arthritis and things like that. A lot of times these drugs are prescribed for chronic non-cancer pain, and so one of the things that we're trying to do, and I can talk a little bit more next week about our opioid prescribing guideline, is develop tools for physicians to look at alternatives to opioids. I think there has been sort of a trend in our country over time to increase prescribing opioids because it was sort of seen as a way to deal with pain, as pain became sort of the fifth vital sign and something we recognized more in this country as a need. And that sort of led to a boomerang effect of over-prescribing, and now we're really looking at what are some of the alternatives to prescribing opioids. Maybe it's things like physical therapy or cognitive behavioral therapy to try to address pain issues, or non-opioid pharmacological therapies like Advil and things like that, ibuprofen. So there's a lot of different reasons that it can be happening, but to get better information on your county, some of the resources that were mentioned here will help you get a better sense of what your county looks like.
That's terrific. And we also will be sending out that resource as well as several other that can help people identify where the areas of greatest concern are around the country. I think a lot of the other questions are coming in that may be answered in our next segment of our webinar today. So why don't we turn the presentation now over to Dr. Campopiano with the SAMHSA, the Center for Substance Abuse Treatment at SAMHSA, and have us go into the next section of our presentation today.
So good afternoon, everybody. I'm getting set up here to make sure you can see my screen.
We can see you.
Good, good. Thank you. So good afternoon, good morning to those of you who are participating from further west. I am tasked with talking to you about opioid use disorder, and what I will be covering is basically what is opioid use disorder, why are opioids in particular such a problem, and why do people develop opioid use disorder. Now, to really talk about what is opioid use disorder, and this is the abbreviation that you'll see in my slides, OUD, you have to take kind of a step back and think about substance use disorder. Because from the perspective of human behavior, it really doesn't matter that much what the substance is. I will talk about the specific ways that opioids are challenging and harmful, but really it's about human behavior. So I'm going to harken back to the father of American psychiatry and signer of the Declaration of Independence, Benjamin Rush, who described alcohol use disorder in the language of his day. And I think that it still describes what many of us have observed or experienced in observing people with substance use. So what he says is the use of strong drink is at first the effect of free agency. So that's what we talk about today, which is, you pick up the drug or the drink yourself, out of free will initially. He goes on to say that from habit, it takes place from necessity. So it becomes a habit, and then it becomes a need. And he says that he has made this conclusion because he says, this is the case, I infer, from persons who are inordinately devoted to the use of ardent spirits, being irreclaimable by all the considerations which domestic obligations, friendship, reputation, property, and sometimes even by those which religion and the love of life can suggest to them. Now, many of us have seen people lose everything through their substance use, and even their most cherished values don't seem to be able to prompt them to behave in a healthier way. So what he was describing were the behaviors that we still manifest today when we have substance use disorder. Now, I'm not going to read all of this bit to you, but he basically goes on to say that, observe that people have sometimes gotten better by motivations drawn from religion or morals. And he speculated even then that more people could get better if we made available and applied remedies of a physical nature. Now, in Dr. Rush's time, they didn't really have anything effective, but he was sort of speculating that we might go in this direction. He also observed that substance use disorder was so very common that he recommended that every city and town in the United States have the capacity to treat it. He also observed, and this was new at the time, that people with substance use disorder deserved compassion, that they were sick, in the same way that people of that era had begun to understand mental illness as an illness and not, being possessed by demons or something like that. So human behavior hasn't changed very much from Dr. Rush's day, and so we still struggle with some of these same concepts today. Now, talking about substance use disorder and opioid use today, we would characterize it as being defined by clinically significant impairments in health, social function, so being a responsible parent, being a responsible employee, and most in particular, voluntary control over one's substance use. So using drugs when you've decided you shouldn't or must not, but you do it anyway. The condition is chronic, meaning you can get better, but you're at risk of relapsing without continued care. And it is influenced by things certainly Dr. Rush didn't know anything about, but genetics and developmental factors. And I'll unpack a little bit of that for you here momentarily. Now, we also know a lot more about the brain today. We know that these three areas are especially important to either being able to resist substance use or developing substance use. So I'm talking about the amygdala, the basal ganglia, the prefrontal cortex. And this little cartoon that we're looking at here is obviously not anatomically accurate. So the areas that we're talking about are in the center and at the base of the brain. These are primitive areas that are solidly wired into emotions, to survival, and kind of getting survival needs met. So when these areas are disrupted by substance use usually, but also by trauma or mental illness, this will contribute to the onset and development and continuation of substance use disorder. I'll look at that a little bit more for you. See if this will advance. There we go. So disruptions of these parts of the brain enable substance-associated cues or events in the environment or behaviors of people around you to trigger your substance-seeking behavior. When these areas of the brain are disturbed, one's sensitivity to the experience of pleasure is reduced. So you need a more strong stimulus to feel the pleasure that we need as humans to go through life. It also increases the activation of stress systems. So things that would be kind of an average stress become a more intensely stressful experience when the person's brain has been disrupted by substance use. The other important thing is that substance use and the disturbance of these areas of the brain reduces the abilities of the brain to exert executive control over some of the impulses and emotions and assure thoughtful decision making. So in a way, most of us have experienced adolescents being impulsive and making bad decisions, and their executive control systems haven't really developed yet. So when you interfere with the executive control systems of the brain, the person's behavior becomes a little bit more like an adolescent. So the other important things to know are that experiencing withdrawal and experiencing tolerance by themselves are not the basis which you can say this person has a substance use disorder. And that's because withdrawal and tolerance can be a normal response to medication when it's taken as directed. So a person who's on pain medication may become tolerant to it, and they may experience withdrawal when they stop taking it, even though they take it as directed. And that does not mean that they have a substance use disorder. It's the behaviors of how they use the medication, how they feel about the medication, how they cope with stress, and all the other things that define a substance use disorder. Now, let's talk just a little bit about kind of why are opioids a special problem. And I'm not a historian, but I do like to point out that the earliest description of the effects of opioids in Western medical literature is from 1701, Dr. John Jones, who was an English physician, and he described exactly what all of us still observe today when somebody ingests an opioid, including overdose. And he pointed out that these medications are effective, but he also described tolerance and withdrawal, and noted and described the phenomenon of what happens when you've been taking it regularly and you stop. He described that as long and lavish use. And he talked about the need to develop a safe and innocent or harmless form of opioids so that we could continue to have pain relief without causing overdose and these other problems that he described. Now, we're still looking for this today, and to some extent, our quest for this is contributing to our current problem. So we've seen medications that were formulated and put forward as being safer and more innocent, if you will, and that led to problems. And some of you may know or may not know that heroin was originally a pharmaceutical product from a little over 100 years ago. It was developed to be a cough medicine, which I suppose was pretty rational at the time because many people, there were flu epidemics and pneumonia was a common cause of death. So a cough medicine that was effective was a really valuable thing to have. But obviously it's had its consequences. Now, I'm going to cover how people get opioid use disorder, because I think we've all experienced knowing two different people who have maybe had pain, gotten a prescription, and one ends up in terrible trouble with dependent, chronic, compulsive, or harmful use, and the other one doesn't. So why does that happen? I'm going to kind of break it out into a little graphic here for you of how do we end up with this subset of people with dependent, chronic, compulsive, or harmful use. Very often, it starts with pediatric, hazardous, or harmful substance use. So basically any substance use, alcohol, tobacco, or an illicit substance in a young person, an adolescent or younger, should be considered hazardous or harmful. It's very harmful to the developing brain. But that early exposure is very strongly associated with going on to develop dependent, chronic, compulsive, or harmful use. For example, 40% of people with alcohol use disorder were drinking excessively, not necessarily diagnosed with alcohol use disorder, but drinking excessively by late adolescence. So this is, unfortunately, if you want to think of it this way, is kind of the pipeline to trouble later in life. Now, what causes some children to engage in hazardous or harmful substance use? We know that biology and genes has a contribution, and there's not necessarily very much you can do to modify that, but there are modifiable risk factors. For example, for some young people, their substance use is adaptive, and by that I mean it's a way of coping with hardship and trauma in their life as young people. And so obviously that's something that we as a society have the potential to change. There's also availability. If substances are available when you're young and your executive functions are not very sophisticated yet, you're more likely to make a bad decision and choose to see what that's like. So that's another area where prevention can be very effective. Now, the other variables to consider are what makes people get stuck on this dependent, chronic, compulsive, or harmful use end of the spectrum. And in many cases, it's what you might call social harm or trauma. So it can be, getting trapped in a violent relationship, not completing your education, not having resources to support yourself, getting a criminal record, and becoming kind of functionally unemployable as a result of that. So there's some social harms. The other thing that's a big, big factor is dual diagnosis. And that means if you have like a depression or anxiety or other mental illness, it makes it much more likely that you will have dependent, chronic, compulsive, or harmful substance use and be less able to get better from it. Now, you'll notice this big hole in the middle here. And this is important because most illness and injury, and very much of overdose, happens to people who are not necessarily dependent, chronic, compulsive, or harmful users, but rather are just hazardous users, meaning, who's really supposed to be using heroin anyway? No one. So you may be an occasional user of an opioid, and you're at risk of overdose. You're at risk of getting HIV or hepatitis. So there's this smaller population of dependent, chronic, compulsive, or harmful users who need treatment, and there's this big group of people who are maybe occasional users, which is defined as hazardous, and they need education and they need help developing the motivation to make better, healthier decisions. Now, this kind of pulls out some of what I just talked you through and aligns the risks that I was describing with the corresponding protective factor. So these are things that communities can work on enhancing, and these are particularly for young people, since that's where prevention kind of gets its biggest bang for its buck. So early impulsive behavior can be normal in adolescence, but not everybody gets to learn how to control that behavior. So the protective factor is learning self-control. And that can be something that you learn from adults in your community, whether it's your faith community or some other adult role models. Poor social skills can be offset by positive relationships with adults and positive friendships. Lack of parental supervision can be countered with parental support. Similarly, academic challenges can be responded to with tutoring and other forms of developing academic competence. Reducing availability of drugs, and poverty is a difficult nut to crack, but we find that these positive relationships and strong communities of humans can help offset some of the impact and challenge that poverty presents to young people and families. So what SAMHSA's goal is for people with substance use disorder is recovery. And this is our goal because we've learned from people in recovery that that is what needs to happen. That's what gets you past your substance use, is not, getting into treatment and having a 28-day treatment episode. It's deciding and setting your sights on recovery. And so we worked out a definition with the input from a lot of people with lived firsthand experience. And recovery, the definition that we work with is that it's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Now, there is no medication on the planet that is going to do that for anybody. Some people, and particularly people with opioid use disorder, need medication to stay alive, and some of them will need it for an extended period. But it's a community effort to welcome people and open the door to recovery for people. It's not something that can be prescribed, and that's what makes talking to you today so very exciting for me. And next week is going to be when I talk to you more about kind of the technicalities, the ins and outs of how do you treat this, what are the medications, and how do you interact with those with social supports and so on. So I'll stop there for right now and hand it back so we can do some questions.
Well, thank you, Dr. Campopiano. That was just a stellar conversation and presentation. Thank you so much, and I do appreciate that you've kind of teed up where we're going next week when we see that the many variables that impact the risk of substance use disorder get us into the whole conversation about prevention and the role of community and be proactively leaning into the things that support human flourishing from an early age on. So I just think that we're really excited to continue that conversation. But we do have several questions that we'd like to relate to both you and Sarah. The first one really, I think, is to both presenters, and it's really talking about how different populations are experiencing the opioid epidemic and crisis and addiction. And it's really how are the challenges different in rural and urban contexts, but also how is that relevant also to ethnic and racial disparities related to this crisis? And I think that's to both of you who would like to just talk about just the population issue and the particular nature as it relates to communities, both demographically and population communities. Sarah, do you want to start on that?
Okay, sure. That's a great question. I'll just say a couple of things. I'm sure there's a lot of different factors, but one thing I know we're looking at in terms of sort of the rural-urban issue, and I think this also gets into populations like American Indian, Alaska Native populations and different groups like that. Access to things like treatment and services varies considerably for rural populations versus urban, and so there may be great opportunity to access things like physical therapy and some of the non-opioid therapies that I mentioned earlier when we're talking about pain treatment that aren't available in rural areas. And so like one of the things that we're looking at, and I know HRSA has some programs looking at this too, is telemedicine as a way to address pain issues and possibly also opioid use disorders for rural populations. That's definitely one issue. So I think just access and availability of alternatives, and then I think there's probably also some cultural issues that occur in rural areas versus urban areas that might make seeking treatment and things like that possibly more stigmatizing or less accessible from sort of a cultural standpoint. So that's maybe what I'll start with, and I'm sure there's a lot of other things. But Dr. Campopiano, do you have other thoughts?
Yeah, I think it's important that we not underestimate the sort of multiplying effect that health disparities can have. If you're already subject to inferior medical treatment, either because there are not specialists or the right types of care in your neighborhood, or you're unable to access it because you lack funds or insurance or transportation, that adding substance use to that is going to magnify those disparities. And I also think it's very important, since we're talking about an illness that is situated in the brain, that we consider the role of personal but also historic trauma in as a risk for picking up that initial substance, but also as something that perpetuates the use of substances almost as a coping strategy, even though it doesn't help the situation at all. So definitely access, and then we have created this expectation over the last many decades that that we would treat substance use disorder with sort of an episodic or acute, like you would have a crisis, you would go to detox and rehab, and then you would be expected to pick up and move on from there. And we created kind of an unrealistic expectation with that, because this requires a much more persistent, we use chronic medically, and that can sound almost stigmatizing sometimes, but it's in the medical sense, I would hope it's not taken that way. But it just means persistent. It's just something that it's like controlling your weight. You have to change your behavior and then keep your behaviors changed in this healthy direction. The minute you go off your diet, you're going to gain weight. So, the minute you lose the supports that helped you to stop using substances, then, why would be surprised that you would go back to them? So it's a little bit this expectation that a treatment episode will make you better. And that was never likely to be that successful in the long run.
Well, thank you both. And I think, Melinda, you're bringing up such an important dynamic to this whole conversation, which we'll dive into more deeply next week, but the contributing factor of trauma and adverse childhood experiences and the whole realm of factors that can contribute both to someone's predisposition for addiction and also challenges in their recovery. So we look forward to talking about that more richly next week, and also we will be having additional webinars as the months unfold that we can really go into this very, very important space, because it is also in the area of prevention and how communities, faith leaders and community leaders can be very much proactive in leaning into supporting young people and families and individuals and relationships as a part of this whole, the whole picture and image of recovery. So, so while we're in that space, can we switch and we're getting a lot of questions about the role of doctors in this crisis, and I think particularly for this audience, how does one become a really good consumer of pain management? We know we have some folks up in West Virginia who literally the Attorney General's office goes to sporting events to be able to work with athletes and parents, saying that you may have an encounter with a physician over an injury, and the likelihood is that you will. What's the conversation with that physician? How can that be more proactive in consuming both opioids, be on the watch for what's being prescribed, and alternative pain management?
Mm-hmm. Well, if it's okay, I'll start with an answer. This is Melinda. I think that there's kind of two general things. First of all, whenever you're prescribed a medication, you should understand what is it intended to do for you, and also you should understand what happens if I don't take it, because I think health professionals, and I won't limit it to just physicians, I think we're all concerned about relieving suffering. We don't want an injured person or somebody that we've done a procedure to be unable to function due to pain, or to have their ability to recuperate from their illness impeded because they're in pain. But on the other hand, acute pain is not generally life-threatening. So it's possible that an otherwise young, healthy person might be able to recuperate from a sports injury or a minor procedure, without an opioid at all. And I would just encourage people to advocate for themselves and be good consumers the way you would research a product before you bought it. Ask the doctor or nurse practitioner or PA who's prescribing and caring for you, do I really need this medication? What is it going to do for me that's good besides relieve pain? Is it going to get me back to work sooner? Is it going to allow me to return to my athletic activity sooner? And by the way, are either one of those things good? Should I really be going back to work that soon, et cetera? So I think just having that conversation, say, Doc, do I really need this? Will I be okay if I don't take it? And then the second thing is, I think we all, and I know this was part of my experience as a professional and personally, is that people tend to hang on to their medicines. And we've got to stop that. We have got to stop that. We have to make it normal to get rid of your medicine as soon as you're done taking it, and we've got to make it easy to do that. The tendency is to go, oh, it's hard to get an appointment with the doctor and I might need this again, or this medicine they gave me for my wisdom tooth extraction might be good for when I get a migraine. We have to stop thinking like that. And the doctors and other prescribers have to stop being maybe complicit in that, in giving you maybe a little more than you strictly need because they know that that means you won't have to call them the next time you get a migraine. So there's some deep reflection and consideration and some collective behavior change we can all be a part of that would make opioids less available and reduce our own and our loved ones' risks for exposure to opioids and development of opioid use disorder.
This is Sarah. I don't have much to add to that. I think those are really great points. I'll just mention briefly that in relation to the first point about sort of talking to doctors about the prescription and whether it's needed and what it will do, CDC put out opioid prescribing guidelines for primary care physicians last year, and one of the things that we did in relation to that was develop a bunch of materials for patients to help them have a more informed conversation with their doctor, and we'll talk more about that next week. But I think one of the things we sort of recognize through this process is that there's this tendency among doctors to overprescribe, but there's also this tendency for patients to just take the prescription when it's given to them. And I've heard more and more stories of people saying, I got 100 oxycodone for a tooth issue. Not necessary. So, we're really trying to work on the prescribing side to try to develop some standardization and consistency, but also it's so important that patients are informed about the dangers of opioids and that there are potentially alternatives and have that conversation with their doctors. And so that's one of the things that we try to make accessible as part of our opioid materials. And then just the other thing I'll mention in terms of a resource, we have a communication campaign in the works. We piloted it in a few states at the end of 2016 and the beginning of 2017. It's going through the final stages of clearance here at CDC and at HHS, and we're hoping that that'll be more widely available in the next few weeks. And that's really a sort of testimonial-based campaign that helps people understand that opioids are dangerous. I think there's this sort of perception that because they're prescribed that they're safe, and that's one of the things that this campaign is trying to do, is help people understand the dangers. So that might be another resource in terms of sort of the patient or the public side of this discussion.
Well, thank you, Sarah. If that campaign is anything like the one you did for smoking awareness, I'm trying to remember the name of it, it was very powerful, and people could use it on their social, on their tips campaign. Oh, that was incredible. It was downright frightening, but it really got to the point. They were sensitive, but they were also startling, and so that's for anyone's social or for sharing with their community. And also there's another, and folks, I'm going to talk about our toolkit in a moment. On the toolkit, we also link to a whole bunch of resources, and many of them have been mentioned during this webcast, but one in particular is called, I believe it's called Pathways to Hope. I'd have to check it. It's from health.gov, and it's a whole role play of a person going to the doctor, and it's meant to talk to prescribers, the nurses and doctors and people checking people in. But you can easily put yourself in the position of the person and the family supporting that person and understand the moments where the right question wasn't asked or the timely question wasn't asked. So when we send this out to you, I really would recommend that you all take the time to go and look through it for those resources as well. I think we have time for one more question, then I'd like to wrap and then talk about the toolkit a little bit. But I think I just want people to be clear on how the nature of overdose deaths related to opioids tends to be changing on a daily basis. Could you both address just the nature of what's contributing to overdoses?
Sure, this is Sarah. I can start. Okay. Do you want me to start? Is that okay?
Yeah, please, yeah.
Okay. I think one of the things that's really been, I talked a little bit here about those three waves of the epidemic. We are definitely seeing a bit of a tapering off of the prescribing of opioids and deaths related to that, but it's still high. And that's one thing we want to make sure is clear, is that there's still way more prescribing than may be necessary, and there's still way more deaths than are sort of acceptable. We're also, though, seeing this huge wave of deaths, especially sort of in the eastern side of the country, from illicit opioids like fentanyl, and often heroin that's laced with fentanyl. And the reason that the deaths are going up so much is that those are just incredibly potent drugs. So a very small amount of fentanyl, or there's another synthetic opioid called carfentanil, very small doses of that can lead to an overdose. And in terms of reversal, there's tools like naloxone, which are overdose reversing drugs. It can take like 4 administrations of naloxone to reverse an overdose from fentanyl. And so we're seeing this greater potency in some of these illegal drugs that's leading to the increase in overdoses, especially with the illicits. So that's one of the factors. And I'll just stop there just to not try to overcomplicate things. But SAMHSA, do you have other thoughts?
Thanks, Sarah.
Yeah, there are there are a number of important variables, but I think there are 2 that I'll highlight. And one is that people who have lost their tolerance to opioids are at higher risk of overdosing fatally. And that can be someone who was incarcerated, maybe even just for a few days. This can be people coming out of detox and rehab, which is what makes relapse so very dangerous after those types of treatment episodes. So you'll have people who, were trying to do well and were in a hopeful place, and a relapse will prove fatal. So loss of tolerance for whatever reason, a period of abstinence was forced or chosen. The other thing is mixing substances. So you can see overdose more commonly in people who might also be taking other prescription medications, sedatives, sleep aids, that kind of thing, but also, very importantly, alcohol. And many people, drink alcohol, what we call socially, but it shouldn't be consumed with these powerful pain medications. The other thing that I think is happening is, there's been this rollout of overdose prevention and naloxone, and with the advent of fentanyl, death is happening so quickly that even an emergency response and arriving and administering naloxone may not happen fast enough. Heroin, the way it was until quite recently, or prescription opioids, normally caused death sort of slowly, and there was a window of opportunity to intervene and resuscitate someone that was maybe hours long. And that's changed because of the fentanyl, where you may have minutes to respond before someone is permanently harmed or dies as a result of their opioid use. And I'll stop there because I know we're getting towards the end, and I want to hear about the toolkit.
Yeah, we are, and that is really just an important message to send out. We couldn't act quickly enough in some cases. So thank you for that, and we'll continue this conversation next week. We have a great place to wrap up. We got a question from Maria, who is a Girl Scout who joined us on today's webinar, and she's planning an event in her community and wants to know the best resources that are out there for families and friends and community leaders to help with this epidemic and this issue. The toolkit that we have and we'll be sending out to all those who registered, to Maria and everyone who registered for today's call, we are actually literally, it just is releasing as we speak. It's a toolkit. It's meant to be a practical toolkit for faith and community leaders. It outlines ways in which you and your community can support prevention efforts and reduce risk, provide support to those in and seeking recovery, to save lives and prevent future generations from harm, no matter the size or capacity of your community. The toolkit was really informed by the experience and expertise of our community partners who we've talked to extensively over the last several months, and we learned what was working in their communities and congregations. And it was also shaped by our subject matter experts here at the CDC and SAMHSA who are with us today, also the Office of Adolescent Health, the National Institutes of Health, particularly the National Institute on Drug Abuse, as well as other HHS and agencies, try to say that a couple times. But also what we'd mentioned a few times is there's a terrific resource library with links to many excellent resources that will help that from our many agencies that I mentioned, and will really help you explore this issue and what you can do in your community more extensively. And we'll be forwarding a copy of this toolkit to all those who register for today's webinar. It will also be available upon request through partnerships@hhs.gov. That's our email for this, for the Partnerships Center. So Ben, if you could just flip to the last slide, we'll just talk, make sure that, okay. Dates to remember, next week we have our next, the second of our two-part series, August 16th. Where there is hope, treatment, recovery, and prevention. Also, September is leading up to National Recovery Month, where there will be so many things and events and opportunities going on. And then we have a live stream event happening on September 27th. We'll be sending out additional information on that. I'd like to thank Sarah Patterson at the CDC, Dr. Melinda Campopiano at SAMHSA, their teams, my colleague Ben, and mostly all of you for the incredible work you're already doing to help and support those who are struggling with this issue and their families. Thank you. We'll talk next week. We look forward to continuing the conversation. Have a wonderful afternoon. Thanks, friends.
Thank you.